Hello, everyone, and welcome to the first episode of our HoFH Wednesday Webinar Trilogy. My name is Shirel, and I'm an HoFH Patient Ambassador, and I will be moderating today's session. First, I'd like to thank you all for joining us from around the world, I see, for what we believe is very important conversation. But before we begin, I would like to share a few housekeeping notes. Today's webinar is being recorded and will be available online. We encourage you to submit your questions throughout the session using the Q&A box or the chat, and we will address as many questions as possible during the dedicated Q&A segment towards the end of today's webinar. Now, I'm delighted to introduce our speakers that we have on the panel with us today. And Athanasios Pallidis, better known as Thanos, an HoFH Patient Ambassador from Greece. He is also a founding member of LDL Greece, an HoFH Patient Association. Thanos will share his personal journey and reflect on how diagnosis and treatment have shaped his life. We also have Professor Albert Wiegman, pediatric cardiologist from the Netherlands and one of the leaders behind the recent EAS consensus paper on pediatric FH management. And he is also FH Europe Foundation trustee and chair of the Scientific Advisory Committee, who will discuss with us today why early diagnosis is so critical and how recent developments are changing the outlook for children with HoFH. And last but not least, Professor Amy Peterson, pediatric cardiologist at the University of Wisconsin School of Medicine and Public Health in the United States. She serves on the Scientific Advisory Board for the Family Heart Foundation, the American Academy of Pediatrics Committee on Nutrition, and is also the incoming chair for the Young Hearts Cardiovascular Disease Prevention Committee of the American Heart Association. Professor Amy will explore newborn and pediatric screening at what happens after a child is identified. Now, before we hear from our esteemed speakers, and if I may, I would like to share a little bit of my own story and why this topic is so close to my heart. I was diagnosed with HoFH as a child, and when my mom noticed small bumps on my knee, they were yellow, and keep that in mind because we will see later on in Dr. or Professor Albert's presentation what those yellow bumps were. At that time, awareness was very limited, but luckily, and as I said, luckily, my mom had seen similar signs on a distant relative who had sadly passed away from a heart attack. And this is what initially pushed her to take immediate action. Long story short, after visiting several doctors who initially dismissed the signs as not serious or as a skin condition, she insisted on doing a blood test that included a lipid profile or my cholesterol levels. And when the results came back, they were extremely high. And she was told very early on that with that or with such levels, I might not live past the age of 3. But that didn't stop her from advocating, didn't stop her from searching for answers and finding the best healthcare professionals to treat her baby. So it took one determined mother and one highly knowledgeable professor in endocrinology to put me on the right track from the very beginning. I started strict diet, medication, and later when I turned 8, I started apheresis to help keep my cholesterol levels under control and my health stable. Now, the treatment landscape was very different from what it was, from what it is today. And that really matters because it means that children diagnosed now have far more options and a very different outlook compared to before. But we'll explore on that in more details in the next episode. So like many people living with HoFH, my journey has involved challenges, uncertainty, and long treatment. But over the years, one thing has become very clear is that I was very, very lucky that I was put on this difficult but life-saving journey very early on. because when I was identified early, we created an opportunity to start treatment earlier, to prevent cardiovascular disease and to support, the family sooner. So it really gives the children the chance to live healthier future and better quality of life. And this really is why this conversation matters. And it really sets the baseline for all future conversations. So with that, I would like to kick us off or to begin our discussion by hearing a powerful perspective from Thanos. And Thanos, your experience offers a unique insight into what early diagnosis and early treatment can truly mean in real life. So could you please take us through your journey?
Thank you for having me, and well said, Cyril. The truth is, as I was hearing, I could relate on many parts of your journey, especially the word lucky rings different from me from the moment I understood what was going on. I was at an age I could. So a little bit about me. I'm Thanos. I'm an HoFH patient from Greece. I'm 35 years old. And my journey begins at 1994. I was 4 years old at that time. I also had yellowish orange bumps on my elbows, on my knees. Some people also developed them on around the eyes. I didn't have that. In the beginning, my parents were confused. They didn't know what caused that. We also didn't know any other case, so that we could relate. We decided that this is not normal. This is not. If this is a skin condition, it's a complex one. So the first thought would be to go to a dermatologist, and that we did. They decided that I have a skin condition, and they gave me some sort of gel to apply on my skin so that the orange bumps would wither away. They didn't. So after a few weeks, we went to another dermatologist, but they were informed enough, and then it was we were lucky to get to that doctor, because I don't know around that time how many dermatologists knew about the condition. They said that they cannot help us. I should go to a local hospital and check my blood cholesterol levels. And that we did. We went to a local hospital here in Thessaloniki, the northern part. I did have a blood test. I had the total cholesterol of around 800-900. I don't know the LDL C exactly, but you can guess. And but after that, they couldn't offer any solution. They just hospitalized me there for a few days, ran a few more checks on me, but they didn't provide any clear answer. And now I will say something that I don't usually share for time saving, but because usually I describe my whole journey, but since now it's more about the road to diagnosis, I will. So it was the name day of my mother. That's like birthday. We celebrate one time a year our names as well. It was her time, and she got sick and tired of being at the hospital without getting any proper answer about any guidance. So she signed some documents so that I get off the hospital with her responsibility. And as a matter of luck, again, there was something, a report on the TV news describing about how some lipid clinics in the US work on new therapies. Her brother saw that on the TV, called my mother and told her about that. So we at least had somewhere to look at, a direction to move on to. But the thing is, before we got to that point, we also went to another doctor, a cardiologist this time, and I don't remember much, but the message is, what my parents told me is that after he also had some checks, ran some checks on me, he said to my parents, "Do you have another kid?" Meaning focus on the other kid, because this one, it's not going to make it. Something like Cyril, very similar with the doctor saying, obviously that we're not going to make it. So after that, we went to the US embassy locally. My parents did. We tried to find information of some of the lipid clinics. The ambassador there helped us. We got some emails. We sent some emails, and the one I was accepted was in Philadelphia. So I went there. The doctors there ran another blood test check on me. Also, I had genetic testing there. And it was the first time we got a proper diagnosis, not just a diagnosis, but something but a solution suggested as well. So I got my diagnosis there, some sort of guidelines, and then I had a solid document, something to come back in Greece locally and find the right physicians here to get me on treatment. And, this span was from my 4 years old to 5.5, 6 years old. And then I started taking statins. I was doing an earlier version, a different version of what we know today as LDL apheresis. And obviously, it wasn't easy after that point. I had to do my apheresis every 2 weeks. I had to take drugs every day. But I would still say today that the steeper part of the road has already been walked. Even though I don't remember much, I think that the hardest part was already behind us. And I'm saying that because today, at the age of 35, I don't have any CVD. I do have an aortic stenosis of the aortic valve, actually, but it's manageable. I don't have any other findings. And every doctor that has been treating me has been following my case from when I was a kid since now, until now. Even though they don't know each other, they can all unanimously agree on one thing, and that is that it was the early diagnosis. Also, my parents, that what we say here as a saying, they moved mountains in order to do what was best for me. But it was like, how they say, a consensus from them that it is because of my diagnosis that I'm on this point today. And the interesting thing is that my parents and my family as a whole were diagnosed because of me. My father had a blood check in the military. All males have to do here for 1 year at some point. He had a total of 450 cholesterol, but he disregarded it because he was like 32, Marine at the time. So he can't possibly have anything wrong with his body, right? With his cholesterol. And I would also highlight to stress. I would like to highlight that as a patient ambassador and advocate here in our patient group in Greece as well, I've met other fellow HoFH patients. One of them I have in mind, he was diagnosed at the age of 12. And you could say that's still early, right? It's still a pediatric diagnosis. I was diagnosed at 6 years. That was a difference maker. They unfortunately had stenosis plaques, lipid plaques in their carotid arteries, and they had to go through an operation, CVD operation. So if there is any message to be taken from this is that I'm glad that I'm healthy, but I'm also feeling lucky. And that's the thing. It shouldn't be a matter of luck. It shouldn't be an exception, in my case. It should be the normal, the standard thing to do. Thank you very much.
Thank you, Thanos. That brings me on that note. I also have a story about another person living with this condition. He's 14 now, and he had his first stent like a week ago. He had 80% blockage on his main artery. And he was diagnosed when he was 9, but the issue was that miscommunication was had with his mother, and he was set to fail from the early beginning. he was told, or his mother was told, that he will not be living, and she treated him as such. But luckily, again, luck, we keep talking about luck, but it shouldn't be just luck. We should always, stress about awareness and advocate for knowledge. But yeah, now he's on apheresis, and he's taking, control back control on his health. But yeah, I mean, that story is really, we shouldn't, see children go through that anymore, with all the innovation and all the, developments that we see in our day now. Thank you, Athanasios, so much. On that note, also, it also raises an important question or important point in your story. So even when diagnosis happens in childhood, in HoFH, timing is still critical, and every delay matters. And to understand why this urgency exists from a clinical perspective, I would now like to turn to you, Albert. Can you help us understand why every moment matters, and when it comes to diagnosing HoFH?
Thank you for having me, and really important to hear your stories and have excellent parents who think it needs to be diagnosed as early as possible. And that's the main message. We have to find those at high risk at an early age, and sometimes the parents are more helpful than other colleagues. So we want to inform our colleagues as well, but we need ambassadors. And for that reason, I feel comfortable to be one of the ambassadors as well. Shall I show a few slides? If you can help me, Cheryl, and if you have the next. Oh, that's beautiful. Beautiful perspective. Can you build up this slide? If you inherit from both parents, your cholesterol is not just high, but it's mostly, the mean is 5 times the upper limit of normal. So if the upper limit of normal is 3 millimole per liter or 150 milligrams per deciliter, it's above 15 or above 575 milligrams per deciliter. And there is a very short time interval to lower the cholesterol and prevent from heart attack in the future. It's a rare disorder because 1 in 300 or 1 in 275, I think it's more frequent than 1 in 300, means 1 in 275 have a chance of 1 in 4 in their children to give the gene with the variant, the pathogenic variant, the mutation to the child. So that becomes 1 in 300,000. And the child, as this photo beautifully shows, is the product of the parents, the stripes of the t-shirts. Next slide. Here you see it's a matter of like cigarette package years, cholesterol package years. It multiplies every year that it is high. And if the normal in the first 30 years is around 2.5 in the unaffected brothers and sisters, in heterozygous FH it's more than double, and in homozygous FH it's more than 5 to 6 times high. And if you reach at 63 a certain threshold that your chance on a heart attack doubles, it's not that you get a heart attack, but your chance on a heart attack doubles. That happens in heterozygous FH at the age of 33 and in homozygous FH at the age of 11. So I feel really with Thanos, age of 6 or the age of 12 can matter a lot. If you are there younger, you can bend that line. So if the next one, yes, we say we start the treatment from diagnosis, and optimally we want to find them within the first few years of life. But if it's at 6, fine. If it's at 7, please be referred. Next slide. And this is a busy slide. we published 18th of May last month about a registry of more than 950 patients living with homozygous FH. But if you give the next one, I want to focus on the age, the median age of diagnosis, and that's 12, and that's too late. We want to see every homozygous FH as early as possible, preferably in the first 2 years of life, but at least in the first decade of life, because otherwise, next, this is published about a 9-year-old girl with homozygous FH who had chest pain since a week and a cardiac murmur, suval. And she had LDLs of 735 milligrams per deciliter or 19 millimole. And at the right-hand side, you see a heart catheterization. And at the black arrow, there is the origin of the left coronary artery, and that's narrowed. And on the orange arrow, there should have been the right one, and it's completely occluded, it's not visible. The child had a major surgery and survived. So that's the fortunate, but we want to be there earlier. We don't want to have heroes as cardiac surgeons, and luckily they are there, but we want to prevent this. So next slide. And this is what you both mentioned, eruptive xanthomas, bulbs, or orange-like bulbs between the fingers and also at the Achilles tendon, the heel, you can see there, even in the buttock. And sometimes you can see, we call it arcus. It's a ring that starts at 6, but the circle will go on, but mostly you will find it at 6 o'clock, where the yellowness starts in the eye. And that's helpful. If every physician, or at least pediatrician, knows, then they will check the cholesterol and then know this is FH, homozygous FH. Thank you. Next one. And what we found out is if you lower the cholesterol, and if you're able to lower it even below 3 millimole per liter per year, then the atheroma in the vessels shrink and can disappear. If it remains high, it continues to develop. So every lowering helps, and perhaps the best is to lower it below 3. But even if you come from 15 or 16 and you go to 4, that's helpful as well. Next slide. Here you can see that we nowadays don't do hard cath that much because we now have the access to CT scanning, and you can beautifully show the coronary arteries and see the inside of it with low radiation. And at the top you see a 12-year-old and a 17-year-old with plaques in their coronary artery. That is the yellow part. And then after treatment and lowering the cholesterol, in this case with evinacumab, but you can do it with apheresis or with lomitapide, 1.5 years later, the plaques have vanished, were gone. Next, you see that here plaque disappeared. This is important. And for that reason, the 25th of May, we presented a new algorithm, EAS consensus statement. 24 specialists from all over the world said this is the best way to tackle homozygous FH. You aim for an LDL-C below 3, or if there is already some problems with the heart, with the coronary arteries or the aortic valve, you try to go for even lower. 150 milligrams per deciliter is the top, and the other one is 70 milligrams per deciliter. And then next, you see that we say don't give PCSK9 inhibition if there are hardly any LDL receptors left, because they will not work. So skip that and go to the bottom, lipoprotein apheresis, the apheresis, or evinacumab or lomitapide. Next one. because apheresis will help. If you only give statins and ezetimibe, your LDL will lower with 30%. If you add lipoprotein apheresis on it, on top of it, it will lower with 55%. That's helpful. And next one, evinacumab and lomipatide will be discussed in the next webinar. So I will only briefly say, nowadays we have evinacumab from the age of 6 months old in Europe, and in US from 12 months old. It's once per 4 weeks intravenously. And very, very recently, last week, the EMA approved lomipatide, an oral drug from the age of 5, and they both work without LDL receptors. So that's the benefit. Thank you for your attention.
Thank you so much, Albert. We will share more details about the second webinar at the end of this session. Now, you've clearly shown us why early intervention is so critical and how our understanding of HoFH is evolving rapidly, especially with the new guidance and emerging therapies. But knowing this, I think the next question becomes very practical, and I would like to invite Amy. How do we actually identify these children early enough before any complications begins? And can you take us through the pathway from screening to diagnosis?
Absolutely. I just want to thank everyone for the opportunity to speak today, and I particularly, Cheryl and Thanos, want to thank you for sharing your experiences. And I think some of the points I'm about to make are going to just resonate even further based on what you've shared with us. So what my team and some other teams are doing is we're going to try to find homozygous FH from the very beginning. And so what is the very beginning, and why would we want to find homozygous FH at the very beginning? Well, Bert, Thanos, and Cheryl explained very well why we want to find homozygous FH at the very beginning. And the problem that I think every country faces, not just the United States where I practice, is that people don't get their cholesterol checked, is a big part of the problem. And so these are some data from the United States reflecting the current state of cholesterol screening, unfortunately. There is a recommendation in the US that every child get their cholesterol checked between 9 and 11 years of age, but very few children actually have this test done. When we looked at the data, it was about 3 to 4%. Some studies say up to 10% of children in the United States are getting checked at that age group. If children are identified as having risk factors for high cholesterol, meaning it runs in their family, if they have other medical conditions, we do a little bit better. And we will find them around, we get about 27% of kids screened. If we even look at young adults, which is an age group that everyone agrees should have their cholesterol checked, we still don't do much better. About 60% of what we'd call young adults, 20 to 39 years of age, get their cholesterol checked. So attention immediately goes to the one time in a person's life that everyone gets a test done, which for most people is that newborn screening test that gets done shortly after birth, oftentimes before babies even go home. And in the US and in many places around the world, about 99.5% of people have this test done. So it is a really unique opportunity to find FH. This is, I think, also very important because, as Cheryl and Thanos, explained to us, we shouldn't, I love that we have our heroes, like we have our parents, we have our families, we have the doctors that made the diagnosis. I would argue from a practical standpoint, any system that relies on heroes is not going to work. We're going to miss too many people. And I think yours, based on your stories and on what Bert showed us, shows we're missing too many people. And so we shouldn't have a system that relies on heroes to work. And when we ask adult cardiologists in the United States, if you give them a case, like a little test question, basically, less than 30% of them will properly diagnose the heterozygous form of FH. So there are large gaps in the healthcare system and what we practically can expect of our physicians and our healthcare providers. And so what we want to look at with newborn screening is it's really a very unique time in a person's life. And so the requirements for what you want a disease to have or what features you want it to have prior to including it on a panel are fairly strict. And so when I talk about a good disease for newborn screening, I'm not in any way saying it's, an actually good disease. What I mean is it has features that make it a good option to include. And so diseases that it would be a good candidate for newborn screening, the ideal would be that it's causing irreversible disease or death in childhood. And so the strongest cases that you can make to include a disease are for those that require treatment at the time of diagnosis. And as we go through these, I want you to think about homozygous FH and what we know as a disease, but I also want you to think about the heterozygous form of FH as a disease as well, because the immediate answers that you and your HUD give to these sort of questions may be different, and that's where a lot of the complexity lies in this. So almost all conditions that are currently included on newborn screening panels are what we call recessive genetic diseases, meaning you need to have you have the one copy of the gene from your mom, the other one from your dad. Both copies need to have the mutation for a person to have the disease. And they're generally very rare diseases. So what happens is in the newborn screening system, most newborns screen normal. They don't have any diseases identified, and the system relies on that. And their relatives, right? Thanos told us about his family receiving their heterozygous FH diagnosis based on his diagnosis. But in most cases, relatives are considered healthy and they have no health effects. So this gets complicated very quickly. And there's also a matter of informed consent for testing. No countries require written informed consent prior to a newborn screening test being given. And based on this, most countries in general try to avoid what they perceive to be controversial decisions with their screening program or their research programs about newborn screening. And so what happens typically is a baby will have a little poke on their heel, and blood will be dripped onto usually these circles on the newborn screening card. And that card is dried and then mailed to a central laboratory that runs a full panel of testing. And then what happens at least in my state of the United States, any result is reported to the baby's pediatrician, and there is a medical team that has been predetermined and is then activated based on that positive result. And you can see how this could actually be a very nice system for homozygous FH in general. Currently, there is no country that is doing routine newborn screening for homozygous FH. However, it is being done on a research basis in some countries. There are genetic testing research programs in the US that will identify a child with homozygous FH. Interestingly, there's no research program that I'm aware of that is identifying newborns with heterozygous FH, which I have lots of thoughts on that, and I'm sure people on this call do too. And what our team is doing is we're actually taking a slightly different approach, whereas we're trying to measure cholesterol on the dried blood spot, and then if the cholesterol is above a certain level, go on to genetic testing to make the diagnosis. And so good things that can happen. I think many people here on the call would agree that these are all good. We get everyone tested for FH, which is probably the biggest perk to newborn screening. We can find homozygous FH at birth, and we can actually start treatment at birth, which would be amazing, an amazing opportunity for people. A lot of people with high cholesterol think they just need to eat healthier and get more exercise, and unfortunately, their doctors can reinforce that message. And this way of testing may actually help people understand that this is a genetic form of high cholesterol where we can't solve it just by eating healthy and getting exercise. We can find babies' relatives decades earlier than we currently do who have heterozygous or homozygous FH. and we can start that heart healthy lifestyle at birth. And for children with heterozygous FH, we can actually start their statin at age 6 because we'll know about the disease in advance. There are some potential downsides, however, that still need to be taken into account and what make this situation a little more complicated. So anytime you make a diagnosis, there's misinformation and misunderstanding. And if you have a healthcare system, right, that is not, like Thanos explained, that is not prepared to properly diagnose and treat individuals with these conditions, you can create a lot of harm by having these people present for attention with a system that's not prepared to help them. In some parts of the world, there can be difficulties accessing life insurance, or individuals can face discrimination due to their diagnosis. Anytime you have a genetic condition, you could potentially disrupt families if you can demonstrate through the testing that individuals who are thought to be a parent of the child turn out to not be the parent of a child. And also, we don't know yet if what happens with babies who have high cholesterol but don't have a genetic mutation. And we can definitely create anxiety or helplessness feelings from that time of diagnosis as well. So there are some potential downsides to newborn screening for these conditions. However, if we can come up with a way together to effectively intervene and lower cardiovascular risk in childhood, this may, as a world, be the single biggest opportunity we have to improve the health of humans around the world. When we have children diagnosed with these conditions at a young age, we are able to bring them into treatment in a tertiary center. And our clinic in particular, we really emphasize non-traumatic management for children, meaning we take a lot of trouble to make blood draws not a problem and as easy as possible, treatment options as easy as possible for families to be able to incorporate into their life and be able to go on living a full life despite having these medical conditions. So thank you so much for the opportunity to share this information. I look forward to our discussion.
Thank you, Amy. That really, I think, puts things into perspective. You know, intervening early in childhood may be one of the most powerful opportunities we have to change long-term health outcomes. And I also believe, and I loved your comment about the family genetic testing and family decision-making, because I believe that how every step is handled can also shape how families feel about healthcare for the rest of their lives. And I was going to ask you,
absolutely.
I was going to ask you if you have seen parents change their mind about screening or testing after initially being hesitant, and what helped them, you know, feel more comfortable, and what the factors that could play into this decision making.
Yeah, no, absolutely. I've seen families change their mind about screening after meeting with us. I think fundamentally, people want to do the right thing and people want to help their children, right? So I will have many cases where a parent is reluctant to take medication, but they absolutely will give it to their child if they think it's what their child needs to be healthy. And so I think a lot of where you can help people too is realizing, you know, your most powerful tool that you have to improve the health of your child is yourself and your own health. So if you are not taking care of yourself, how are you going to be able to take care of your child? And I think that resonates with a lot of people.
Thank you. And also you mentioned some difficulties screening for heterozygous FH. And on that note, I would also like to ask an open question, if I may, to all of you. We know that HoFH emerges in families affected by FH. There is no HoFH without FH. And identifying FH could be an effective strategy to detect children with HoFH. However, some may argue that because FH affects only 1 in 250 people, it should not be considered a priority in public health compared to other conditions. So from both a clinical and public health and also patient perspective, how would you respond to that? And I would like to start with you, Amy.
So, yeah, it's a really good question. On one hand, right, it's not what some people would consider a common condition, but on the other hand, it's definitely not rare. for a genetic condition, the heterozygous form of FH is actually incredibly common, and it's one of the most common life-threatening genetic conditions in humans. And I would argue, given that it is relatively common, and for individuals with heterozygous FH in particular, treatment for a lot of those people can be delivered in a very safe, very cost-effective way. And so, so I would argue that the screening and treatment needs to be in place because these are not rare diseases.
Thank you. And Albert, I would like also to ask you, because we've seen some people say also that many countries already have cascade screening programs in place. So why should we continue pushing conversation around universal screening versus cascade screening?
It's good to have these types of discussion, but I think the most important is that every country should screen. And the way in the Netherlands is successful with cascade, in Slovenia, Bavaria and Germany, it's successful with universal, but not screening is not an option. So that would be the message. If you don't screen, then you wait till wrong things happen. And if you start screening, and you can do either way, and I think Amy is ahead with newborn screening. Some others are trying to do that as well, and that's really hopeful for the future. So I think it's yeah, an important thing to start. And if you don't start, that's no good in any way. And it's not that rare, because I think in the Netherlands it will be 1 in 250,000, so it's 4 per million. Every country can calculate how many million inhabitants times 4 people should be there with homozygous FH. Are they already discovered? There is a need to find them as early as possible. In the meantime, I agree with Amy, the heterozygous FH, we now want to start in heterozygous FH ideally from the age of 6 instead of 8. Mm-hmm. So that's really young as well.
That's a conversation we should keep having. And Thanos, do you have any, from a patient perspective, what would you say to anyone debating whether identifying children earlier is worth the investment?
I would agree with both Amy and Albert about the importance of getting early diagnosed. And no, FH is not really rare. It's one of the most common life-threatening genetic disorders. And it's not just getting the diagnosis for the sake of diagnosis. We talked earlier about how we got diagnosed, and I also highlighted the lack of many options. It's not the same today. We have so many different therapeutic options compared to what it was back in the day. So having an early diagnosis and also having a regulated cholesterol and proper treatment is also cost-saving, life-saving. Obviously, tackling down obesity is very important, but everybody knows about obesity today. Even the people around me, if I ask somebody about what's healthy and what's not, and the healthy life, not everybody knows, obviously, but they do. Whereas we don't even have, we do have the tools to tackle FH, and but we have to be aware of it.
Mm-hmm. Again, keeping the conversation going. So, questions to the audience. If you have any questions, please feel free, again, as a reminder, to submit them in the chat or in the Q&A box. We do have a couple of questions. One is for Professor Albert. Is Arcus cornea always present in untreated HoFH patients?
Not always, but rather frequent. So sometimes an eye specialist is the first one who diagnoses homozygous FH. The same is for dermatologists, who are the first to see. We have to train the dermatologist and eye specialist. This is a very serious condition. If this occurs in the first decade of life, then it's highly probable homozygous FH. If it occurs, let's say, at the age of 30, it can be a sign of heterozygous FH. And if it occurs at the age of 50, 60, then it's just due to an elderly person. But if it's there in the first decade of life, it's the first sign.
Thank you. We also have another question. I guess it's for both experts. What if you have HoFH together with high Lp(a)? What is the impact? Amy, would you like to start?
Yeah, sure. So, both homozygous FH and high lipoprotein A are going to make atherosclerosis and that plaque development happen faster. Some of the medications that we use to treat homozygous FH also have an effect of lowering lipoprotein A levels, which is good. There are treatments coming that will specifically help us lower lipoprotein A, but it's a very good thing that everyone certainly with heterozygous and homozygous FH, and some people would even say all adults, should have their lipoprotein A checked. It's an important thing for you and your doctor to work into your treatment plan.
Yeah, I can agree and add to that. We did trials in homozygous FH with PCSK9 inhibitors, and we saw a lowering of LDL of around 25 to 30%. The same happened with evinacumab. I'm not aware of lomitapide, but probably it will do as well. So, yeah. But the next, the pelacarsen, olpasiran, lepodisiran, serlaciran, and muvalaplin, the 5 drugs that will lower LDL with 80 to 90%, will help to prevent from early developing specifically aortic valve stenosis and strokes. So it's a new drug that will help prevent from having that as a problem.
On that note, I only tested Lp(a) because I was involved in this foundation, and I've been exposed a lot of about information about Lp(a), and I want to ask Thanos if you had your Lp(a) tested.
I did once, well, I also this network is an opportunity for us to also get educated about similar lipid conditions. So I did have my LPA test, and the interesting thing is that you only need to do it once in order to get your diagnosis, right?
Sure.
So I think all people should do it once in their life.
I think if you're a very young child getting it checked for the first time, it probably makes sense to test it again when you're an adult. But generally, yeah, for most people, if you're tested for the first time as an adult, you're right, Thanos. Your level does not really change very much.
No.
Thank you. Now I'd like to switch a bit to the parents and the families that are getting diagnosed. I know, Amy, we've talked about your work with children and families and the rehearsals, and you've talked about needle phobia and how you handle the children journey and how you want to make it as least painful or less damaging, if I may say, for them as possible. I would love to know more about how you support families through their journey.
Yeah, absolutely. So we call it needle phobia. So the when children and adults too have a fear of getting a blood sample collected to measure their cholesterol, or fear of having a needle placed to receive an infusion. It's a big problem. On one hand, it's easy to sort of think, oh, surely that can't be that much of a problem, but it actually can be a very serious problem. And if you think about it, if you're treating someone with a medical condition that affects them their whole life, if they have a lot of fear and they've been spent a lot of their childhood scared because of their treatment or feeling like they're in pain, they're not going to want to continue to see doctors when they get older and they have to make the decision for themselves. So we work very hard to minimize that stress and that pain. Some of that is working with people who are very experienced drawing blood and starting IVs on children. So very highly trained individuals. Some of us can access those people, some of us really don't. But there's actually, as a parent, things you can do. So there's some techniques where and little devices you can buy online that will create vibration and coolness around the area of a blood draw that makes it less noticeable. There's also creams that your doctor can prescribe that will numb up the skin and keep the initial poke from feeling as painful. And most people, if they can have their first several experiences be not traumatic as a young child, that goes a very long way. If you have someone who comes to you and has already had trauma from multiple painful experiences, that takes a lot longer to help people get comfortable.
Yeah. I 100% agree and relate, because my first experience with apheresis was not good, and I refused to go back to apheresis for a year, which, you know, it's a big no in the HoFH patient and children with HoFH. Yeah. So, yeah, it's really, really important, and I'm glad you're bringing this topic, shine light to this topic. Thanos, we have a few minutes left, and I would like to ask you, did starting treatment at a young age negatively impacted your quality of life, or do you view those experiences a bit differently today? And how do you feel those early interventions played a role in your life?
I would go with the latter. I see them very differently, my experiences, compared to what I used to believe about them. That's why I said earlier that although I don't have many memories of when I was diagnosed the earlier years, I would still say that was the steep part of the road, exactly because everything after that, it was controlled. Even if we didn't have the means that we have today, the treatment options that we had today, I could at least feel the safety of we know where we're going, we know what's available for us. Back in the day, obviously, I hated it. I was a kid. I didn't know any better. But thinking about it now, yes, but it's normal, right? But thinking about it now, no, it's the uncertainty that hurt me the most, not the needles, nor the LDL apheresis as a whole, nor the drug, nor anything. It was the uncertainty that will I have at the time new treatments that will fully regulate my cholesterol, let's say. So I can only imagine how it was if I felt that kind of uncertainty, but at least I was being treated. Can you imagine what my parents went through mentally about that, the uncertainty they had? So yeah, if somebody asks me today, I would say that I'm glad that I had it the way I did. It was a coin toss for my parents for my mother's brother to see that on the TV news about the lipid clinics in the US. And then we went there. I think that's scary. I'm glad that it went the way it did, but it's scary if you think about it. It's a coin toss. I didn't have to experience this, despite all the hardships and everything after that. No, I would say that I'm glad. I see my memories in a positive light compared to what I was thinking about at that time.
Yes.
Can I add to that? Thank you that you mentioned this. The same happens with children with heterozygous FH. They feel they have control instead of afraid. Many say, don't bother the children with it. No, you tell them they have heterozygous, most of have heterozygous FH, and you have to do this, that, and that. And then they feel more in control. So thank you for making this clear. I have the same experience with these children.
I agree.
Thank you so much. I always say that every year that 1 hour is not enough for our discussions and our conversations. But it's one thing that I'm sure Magdalena will approve, that we start on time and we finish on time. So thank you so much for you. And as we come to the end of today's session, one message really stands out very clearly is that early diagnosis do change life, but what the session also shown us is something equally important, is that diagnosis is only the beginning. How we support children and families through that journey is just as critical. We would also like to thank our partners. This initiative is endorsed by the European Atherosclerosis Society and the International Atherosclerosis Society. We would also like to thank our allies and sponsors. This campaign was made possible through the support of Chiesi and Ultragenics, so thank you so much. And lastly, thank you to our speakers for your time and insights, and thank you to everyone who joined us today, and we wish you a great rest of your evening.